I don't normally dress like this for talk on the war on diabetes. This is a somewhat unusual situation. Actually, both Yong Kang and myself were at a previous meeting. We rushed over from the previous meeting to come and join you. And interestingly enough, both of us are senior commanders in the SAF, NS commanders, and we were both at the same meeting in the SAF before coming here. And we had this little bit of dilemma because we're trying to figure out that meeting's supposed to end at about 5:06. How? And we all decided to leave halfway through. But it was also a bit of a difficult dilemma for us because we weren't sure what to wear. The dress code for that other meeting was, as you can see, what I'm wearing now. And Z decided to buck the trend, and he was one of the few people in that meeting wearing civilian wear. He actually started off by apologizing why he was not wearing the dress code. So now I'm here, and I'm wearing clearly something that's not the normal dress code, the reverse, and it's now my turn to apologize for why I seem to be all decked up and all enthusiastic about running the war on diabetes. So it's a bit of an unusual situation for the two of us, but I think it's a pleasure for two of us to come and share a little bit, perhaps provide a little bit of insights in terms of how the war of diabetes came about, and also perhaps to let you know why we think the war on diabetes is not a war on diabetes on its own. And in fact, it's an initiative, perhaps led by the Ministry of Health, a whole of government initiative that lends itself to, in fact, doing something very meaningful for the health of our population moving in through the next few decades. And in a sense, this is completely aligned, and I'll share why later, with our national strategies, what we describe as Beyond Healthcare 2020, and the three beyonds of which many of you are quite familiar with. So we'll start off first by talking a little bit about the road to war. And I say this not flippantly, but to share the context in which it led us in the Ministry of Health to literally declare war. The only ministry, right, since Singapore's independence, to declare war in Parliament and actually say it outright. But it's a challenge because while we've always been engaged in a fight in diabetes, a war sometimes does raise the severity and the impact, the importance of this work we're doing, but sometimes gives the sense that a war can be won. A war is difficult to win, all right? And this is an ongoing journey that we always have, managing diabetes and the risks associated with getting diabetes. We are living longer, and we are proud of the fact that in Singapore, we have many health indicators that suggest that, in fact, we're doing relatively well. On the surface, that is so, but if we do a deep dive, you will realize that there are, in fact, many issues that we can be very concerned about, and it raises a concern for the future as well because of the trends that we see as we look at our young getting older and the possibility that they will also get medical issues. So while we live long and our life expectancy globally has been increasing over the years, it's also important to appreciate that while we are living longer, it is not necessarily the case that we're living healthier. This is a trend chart that gives you an idea in terms of the increase in life expectancies over the years. But there's also this notion of healthy life expectancy. In other words, the number of years you will spend in health, in good health, as opposed to the years that you have now in illness. And if I plot the same graph for the same group of people, looking at just health life expectancies, you see a slightly different picture. If you look at the graph, you realize that for men and women consistently, the graphs are not the same as life expectancy because we know that there will be a certain proportion of our life spent in ill health. That often is towards the tail end when we start getting chronic medical conditions, and sometimes those chronic medical conditions may worsen to the extent of also being associated with life-threatening complications that lead us then to be using a lot of our healthcare resources in the country. So, if we look at it, that's a difference of 9 years for women and a difference of 7.5 years for men between living your full life and living a good life. There are differences here. So if we look at it a little bit further, in terms of the trends that we see in our population, we realize that in fact, there is a significant proportion of our population that do have chronic medical conditions. The chart here gives you an example of the common chronic medical conditions that we see in any of our primary care clinics are polyclinics. We call it very simply DHL for diabetes, hypertension, and lipid problems or hyperlipidemia. The rates do vary based on ethnic groups, but across the board, these are not insignificant. With it comes the risk that you will get complications, and this becomes the significant proportion of our population, particularly in their senior years, that in fact the rest of us in the healthcare system are very concerned about. Our population also have risk factors, not just whether or not they're going to get a chronic medical condition, but they have risk factors that predispose them towards getting these same chronic medical conditions. In terms of smoking, in terms of having a sedentary lifestyle, in terms of obesity. And while this may be a snapshot looking at the health surveillance surveys that we do from time to time, if we deep dive, we see this trend continuing without a clear sense that it's going to stop. For example, we look over time at Singapore residents, we look at their weights. The average weight for Singaporean has continued to increase. All right? BMIs have increased as well. Our kids are getting bigger. Tailors are finding it more difficult to use standard sizes for students' uniforms. They have to invent new sizes because kids are getting bigger as well. And that's a trend that we see continuing at this time. If I look at the prevalence of diabetes among ODAC countries, we have the proud, bad reputation, if you want to call it that, of being second only to the US. And the US is not a role model for us either. And if we look at projections of our trends, we are concerned. If you look at where the green line is, this is green. These are data and work that's done by our colleagues in Salisbury School of Public Health. They've looked at the incidence of diabetes. They've looked at various etiological and risk factors, and they have studied this. If it's due to aging on its own, and you can argue that the incidence of diabetes is continuing to rise because we have an aging population, that is true, but that rise would be along a certain trajectory that's defined by the green line. But if you look carefully, there are other risk factors for diabetes that our population has. And we talked about it just now, obesity being a big one. And if the rates of obesity continue to rise, the trend, the trajectory for getting diabetes, in fact, is not the green line. It's the red line. And that is frightening because if we follow that red line, 1 in 5 Singaporeans will be diabetic by 2050. And these are some of the figures that we bandy about to create a sense of urgency why we think diabetes is a problem for us. It may not be something that's so apparent now, but when I look at this audience and there may be 200 over of us, throw a stone, 1 in 5 of you getting diabetes, and perhaps then progressing on to worse problems, this is a problem for us. Not maybe now that we appreciate, but a problem that will be a real one for the future. And if you look carefully at the same graph, where we are now, 2017, we are literally at the inflection point, right? Close to that inflection point between the red and green curves. That if we want to do something, we might be able to decrease the curve more towards what the green line is. But we fail to do something decisively, the inexorable trend is as you see here in that red line. So this perhaps is a way of allowing you to understand why we think it's important that we need to deal with this problem. Diabetes is not something to be dismissed. It is a major health problem for us in Singapore. And it will continue to be so if we don't do anything about it, and it will cause us problems. And this is the reason why last year we announced at the COS speech that Minister had that we're going to launch a war on diabetes. And a war on diabetes is not a term to be bandied about lightly. A war is not something we engage in lightly. This is a war that in fact is going to have to see us through the long haul. No easy successes, no quick fights, no quick wins. And there will never be a situation where we'll say, like smallpox, that we can eradicate diabetes in the entire country. That's not the case. But we hope through the journey that we will take together as a nation, as a health system, that we can put the building blocks in place, to put the infrastructure in place that allow us now to create a set of services, a set of interventions, a set of strategies that may help us to shift that curve, what we saw just now. So the vision and the aim we have is to mobilize an entire country. This is not a fight that will only be done by us here in this room. It's a journey that we will take with our partners and stakeholders. And the partners are not necessarily people that are immediately dealing with health right now. In fact, the stakeholders we've engaged in over the last 18, 20 months, and even before that, before we launched an official war on diabetes, have been in many arenas. Yong Kang and his organization is heavily involved with engagement with the food and beverage industry for one. And there are many other industry partners that all have to come collectively together in order for us to get our act together to do something right here. We want to create a supportive environment for all of us. And if we can, create a set of circumstances that allows us to shift that curve so that more people can live a life free from diabetes. But we don't promise that no one will get diabetes. But if you do, then we want to be able to create a set of circumstances that will allow you to manage your diabetes well. And we hope to delay that trajectory to a worse outcome. And this is the reason why we are coming together talking about the war on diabetes. But we have challenges. And the challenges are real because we're starting out with a relatively low base. It's easy if we start out in a position of comfort and to say then that we have quick wins and that is it, the game is over. We're starting out with a challenging set of circumstances because there are real problems with the risk factors that Singaporeans have. For one, Singaporeans eat poorly. And Yong Kang and his team will be really at the coalface to be able to tell you this because they have charted and done surveys looking at how Singaporeans eat. And we know the type of diet that our Singaporeans have. We're eating a lot of excessive calories and we're eating poor food. And therefore, it is not unreasonable for us to think that we have to do something in this particular space if we think we want to change the risk and prevalence of diabetes. But not only that, we're not just eating poorly, we're living a very sedentary lifestyle. Singaporeans don't like to exercise. If we exercise our mouth. As you all know, we are now in the midst of the Healthy Lifestyle Week. And this is the third year, I think, that we're doing the STEP Challenge. And there are long queues at the foyer of the Health Promotion Board downstairs for people lining up trying to get their free step tracker. All right? In fact, HPB has in fact looked at the data from the first 2 years of how people are walking, exercising, carrying out daily activities because they're wearing step trackers. So we can in fact track some of these activities. And already some interesting data is coming out. The most active time of the week, I understand from HPB, is Friday. And maybe it's because of the after-work phenomenon. And that's the only reason why people are active. The least active period is a Sunday. Singaporeans take their day of rest literally. We are a sedentary population, and more can be done in this particular space. Many people don't even know they've got diabetes. And when we carry out surveys, we find that in fact, when it comes to screening, and for those who are picked up to have diabetes, as much as 1 in 3 had no clue at all they had diabetes. That's a large number. And we want to see whether or not we can shift that curve to raise the awareness, getting more people to come, to screen and know what their diabetes status is, because we do not want people not to know that they have this condition. And we believe strongly that earlier treatment and keeping them in good health makes sense to delay that trajectory, that worsening decline subsequently into getting complications associated with diabetes. It makes sense for us to diagnose and detect diabetes where it occurs as early as possible. Some people, even if they know they have diabetes, don't get followed up. And there is, all right, it's not a nice thing to say. We have many screening programs, but we have an issue with getting people then, after being diagnosed to have diabetes, to then come and see a doctor and stay on in a relationship with the doctor. And this issue with follow-up and compliance to follow up bedevils us if we're talking about wanting to have good control for patients who are now diagnosed with diabetes as well. And those whose diabetes are poorly controlled are the ones that will progress on to a worse state of diabetes. Whether it's cardiovascular complications, whether it's kidney failure, whether it's stroke, whether it's the extent of now having poor circulation in the legs, and then with injuries which may initially be minor, leading to a very tragic consequence of them losing their legs, these are serious problems. And at the population level, they are a serious burden to us because as you get these complications, you start using the health services more, you consume more, the cost of care is more. At the population level, this is a big burden for us as a nation to bear. So in the context then of trying to decide what our holistic and global strategy is, we decided very early on that this would be a whole of nation effort. It would not necessarily be only the health ministry taking a leadership in trying to solve this problem. And this is why our national task force, we are famous for forming task force every time we want to do anything, but our national task force has two co-chairmen, the Minister of Health and the Minister of Education. And it's perhaps fitting that the Ministry of Education is also involved with the Ministry of Health in this journey, because many of the interventions and strategies we want to put in place are intended to affect our young, to give them the healthy habits they need so as to stave off that risk that they eventually will then progress to diabetes. If we look in terms of the themes that we want to put in place, then it's clear from our perspective there are three major areas that we think it's important for us to focus our attention on. The first is in terms of trying to stave off and prevent diabetes from occurring. You may have risk factors, but if we can adjust those risks to lower your risk profile in some way, maybe that will help. We're not asking you to change your parents. You can't change your parents. If your parents have diabetes, you already have a family history of diabetes, you have a certain risk that's associated with that fact. But there are many other modifiable risks that we can intervene and do something about. And this is what we intend to look at. Screening is an important part of this journey because I mentioned earlier the need for people to be aware and then to find out what their diabetes status is, to detect diabetes as early as it occurs in any person, so that we can then allow these people to enjoy the best effort to control their disease and therefore reduce the likelihood that they will progress into a more severe form of diabetes. So screening becomes an important effort for us. And of course, the third major thrust is then for those who already have diabetes, we need to figure out strategies to help them to manage their condition well, right? And allow them to be better empowered, to take an active charge of their own health condition, but at the same time, to help them to manage this properly. And these are three major dominant thrusts that we have: preventing, screening, and managing. And if you think about this is in fact very aligned with our global strategies that even preceded what we call the war on diabetes. We talked about three global thrusts: beyond healthcare to health, beyond hospitals to community, beyond quality to value. And if I think in terms of how this relates to these national three strategies, beyond healthcare to health shifts the focus away from talking about disease care, illness management, to talking about trying to promote good health and trying to keep people in as good health as is possible. This is preventive health. This is risk management. This is part of that journey of promoting healthy living that we're talking about. A lot of what we will be doing with screening and to some extent lifestyle interventions, behavioral change to keep people in good health must occur out of hospitals. It cannot occur in our hospitals because it's too late a journey already if that occurs. We want to influence people where they are in their homes, in their communities, because that is where the biggest impact is in changing lives, creating the discipline and habits that are important for healthy living and activity. And therefore, it has to be part of a journey of moving health care services away from a hospital-centric focus to a community-based focus, where primary care takes center stage. And this is beyond hospital to community. And as we talk about improving the quality of care for people who already have diabetes, to provide evidence-based treatments and services, bringing them together in a holistic package that benefits them in a cost-effective way, this is part of the journey we described, beyond quality to value. And if you think about it, the diabetes fight and war that we have resonates very well with our national strategies within Beyond Healthcare 2020. So when it comes to tackling risk factors, there are modifiable risk factors that we can intervene on, but we know there are also those that we may not be able to influence. But in those we can influence, we must do something about it. In a recent edition of JAMA, which is the Journal of the American Medical Association, I think in the 6th of November, just recently coming out, there was a meta-analysis and systemic review looking at various behavioral interventions that have been done in public health, and a clear demonstration that in fact tackling these modifiable risk factors can shift the needle, lowering this curve and preventing some people who otherwise will get diabetes from not getting diabetes. There is evidence to suggest that this works, but we must do something and we must put together strategies to do our bit here. The good thing is that this has collateral benefits beyond diabetes. When the war on diabetes first came out, many of us were asked, why you focus on diabetes? Why not focus on cancer? Why not focus on heart disease? Why not focus on trauma and injuries? But why diabetes? When you think about it, diabetes is a reflection of many of the other long-term conditions that many patients have. The risk factors that predispose to this chronic condition are similar. And if then we can use a label to focus the attention of our entire community and population to coming together, to put together the strategies to dealing with these risk factors, there is an entraining effect. That in fact, while we focus on diabetes, we are in effect focusing on many other conditions as well. So it's not the case that the war on diabetes focuses only on diabetes. It was never the case that we were intending to be so narrow in our focus. But it's a convenient way to bring together, to create a sense of urgency, to create the momentum that allows us to drive the system changes that we need, that leads us to be better positioned for helping to tackle many of the other non-communicable diseases that our population also face. And that's why diabetes is important in that larger sense as well. So this aspect, the first key aspect, is something that we focused on quite a bit for the first 1 year, and we still continue to ramp up some of our efforts in this particular space. HPB is leading in many of the initiatives we're doing here, but this is not an initiative only by HPB. It's an initiative that we're recruiting many other people to come in to help us in this space. For example, we're trying to create healthier food options for Singaporeans. In the system itself, we want to give them a greater amount of choice they have. We want to create a setting where Singaporeans are more naturally going to be choosing those healthy options. We want them to deliberately now eat healthily. But at the same time, as I mentioned earlier, we are a sedentary population. It's important for us now to also think about how we want to encourage Singaporeans to exercise more and have an active lifestyle more. The journey with food has been a very interesting one because it's allowed us, many of us, to develop new insights on how things should be done. You know, when some of us have kids and they're young, you realize it's not easy to get them to eat something they don't like to eat. All right, you need to convince them, you need to find indirect ways of trying to get about doing this. And some of the initiatives we do are indirect. We work behind the scenes with food and beverage manufacturers to try and introduce healthier ingredients. We work with caterers. We work in many food places to make sure that their menus have healthier options, because we want to socialize this such that this becomes a norm, a cultural norm in Singapore. An environmental change in how healthy food is presented and provided for Singaporeans. Some of the initiatives have reached very high popular awareness, because even at this year's National Day rally, PM has also mentioned some of these initiatives. He, for example, has cited how some of our food and beverage companies have now taken the step forward to declare that as part of their portfolio of sugar-sweetened beverages, they want to commit to lowering the sugar content such that it doesn't exceed a certain threshold. And that is good, because that is an amount of engagement that allows us to work with stakeholders in the industry so that this is a shared journey. But we are under no pretense that that is the end point. All right? And therefore, we continue to work at lowering the thresholds, raising the bar, raising the quality of food that will be presented to Singaporeans for their consumption. In government and public service, we have also taken the lead. Right? We have now situations where in any of our public service institutions, you cannot order, I dare say maybe some deep fried stuff may still be present, but you're now more limited in your options, and you must always have water as an example. There is in fact a restriction on the calories, total amount, all right, and therefore more choices are available. The SAF has come in. The canteens, the cookhouses now serve a combination of brown and white rice as opposed to traditional white rice only. So many people are coming together, and the purpose of which is to create that milieu, that environment that allows for us to be able to better enjoy these healthy food choices. We are a lot more savvy also in how we want to communicate and introduce the subtle behavioral incentives for people to make the right choice. And it starts off by raising an awareness so that people are aware of how much calories they consume when they take various food stuff. We don't pretend to have intellectual ownership of this. In fact, many of our hospitals have taken the lead. Even CNA has taken the lead by publicizing the caloric content of mooncakes. And some of our hospitals have gone one extra step, not just publicizing what calories are. Calories sometimes a very abstract notion that people find difficult to understand. If I tell you take a mooncake and you've got to walk 20 flights of stairs to burn off those calories, that caloric exercise or activity equivalent is something now that resonates better with people. And therefore, we're finding new ways of trying to communicate these facts so as to better empower people to make the right decisions. Now, we don't pretend to be the master and the creator of this set of circumstances. In the journey that we have to try and encourage people to be more active in their lifestyle, it is not just a matter of just telling a person to walk more, but you want to create an environment that's more conducive so that naturally they will want to do so. And in fact, we are fortunate that there are many other government agencies and quasi-governmental public agencies that are also involved in this. And they've in fact started some of their work even preceding our war on diabetes. But collectively, we are bringing everyone together so as to better engineer this community setting. So whether or not the parks, national parks, URA, create more park connectors, that is something that facilitates all the campaigns that we have trying to get people to do more in exercise and sports. This, of course, is what you're well familiar with. We shared and talked about it. It is important to appreciate that in this, we encourage the personal and individual effort. We've used different behavioral strategies, including gamification, to create incentives, and we hope that these gamification strategies are not the be-all and the central focus. But what we want is for them to create a habit, so that even at one stage, eventually we move away from giving prizes and vouchers, people will be now already into the discipline of continuing to walk, and therefore they will continue this for life subsequently. But of course, we hope therefore that there's an element of trust. We're not asking the people who lined up in HPB to collect their trackers only to put it around the neck of their dogs and then to leave the dogs to run in the parks, right? That's cheating, right? We do encourage an element of trust that people will do the right thing. The the emphasis on exercise goes beyond just talking about people in their homes. And we're trying also in multiple different spaces to get people involved in this journey of increasing activity, whether for leisure, whether at work. And we realize there are hidden communities even in Singapore who would otherwise, by virtue of their busy schedules, not enjoy the benefits otherwise that we are putting out for them. And therefore, we also have to now start thinking about reaching out to them even in their workplaces, specifically targeting them so that they can, in fact, get onto this journey as well. When it comes to screening, there's multiple efforts put in place to try and increase the opportunities, access for people to come in for screening. And we facilitate some of this work on the back end because we're working actively with the grassroots agencies, giving them data on where we see pockets of increased incidence of diabetes because there's a family effect. People tend to aggregate, and perhaps that allows for more targeted outreach for screening for interventions in the community by our grassroots partners and our regional health systems. We're doing some of this as well. And of course, we are extending screening outreach activities even to taxi drivers when they send the taxis in for taxi servicing. Otherwise, they have to do this every month. And if we don't otherwise do anything, they're just going to sit around waiting for their taxis to be available. Might as well give them that opportunity to also go for screening. So as a taxi gets service, they get service at the same time. And more recently, we introduced the diabetes risk assessment. The purpose is to increase awareness so that people are now aware of what their risks are and therefore to empower and then subtly encourage them to step forward for screening. We provide the screening opportunities, but we need the people in our community to step forward to take advantage of the screening. And that's the purpose and reason why we've brought the DRA tool and made it available. We've also created financial subsidy schemes, therefore to better allow access to care. All right, and the Screen for Life program is extremely affordable. When it comes to talking about disease control, this is a harder situation to manage. And we're now starting to come into figuring out our global strategy of what we want to do over the next 18 months. The first 18 months was focused more on the upstream side of dealing with risk and screening. And we're now starting to focus a lot more on getting evidence-based protocols and guidelines into being to ensure that the care that we provide is the best it can be. This slide summarizes some of the thoughts that we have and some initiatives that we'll bring into being. Includes anchoring chronic disease management, particularly diabetes, within the basket of chronic disease management in primary care. All right, building capacity within primary care to facilitate this. And over the next few years, we'll be creating new models that then facilitate team-based care to be given in the community for diabetics and other people with chronic diseases, some of which exist already, whether it's family medicine centers or FMCs, or CHCs where we bring allied health services into the community for GPs to enjoy. And more recently, we've set up primary care networks, and we already have at least 2, but there will be more primary care networks that will be rolled out over the next year as well. In terms of building capability of our providers, then it's also a journey where we want to better educate healthcare staff so that they can give the best possible care in an evidence-based manner for their patients. We've already started by issuing appropriate care guidelines, 2 of which already have been issued with the diabetes flavor, and more will come. We're looking at various strategies to empower patients better to take ownership so that they can now be co-partnering us in the journey to keep them healthy. We don't want to create an air of dependency where they don't do anything for themselves and depend only on us to provide care. We're also trying to reduce the barriers to appropriate care to make sure then that people don't enjoy care in the wrong place, in the wrong setting. And as part of the journey, we hope to see more patients moving away from hospitals into the primary care environment. We also have various programs looking at preventing retarding diabetic complications. An example of which is what we now call HALT CKD, which comes on the back of a previous program giving certain types of medications, optimizing the control of diabetes in the primary care setting. And in fact, that pilot was highly successful in reducing the risk of people progressing on to having kidney damage. And we're now rolling this out to all polyclinics and progressively subsequently to FMCs and PCNs as well. We are also going to be rolling out enhanced screening programs and services in our polyclinics to try and pick up early signs of eye damage as a result of diabetes, and then to bring them into proper care so as, again, to stave off that risk that these problems progress eventually into blindness. And we have already some programs within our polyclinics. We're trying to strengthen those services, improve the capacity and capability, and roll out such that even patients with diabetes being looked after in CHEST GP clinics would also benefit from some of these services to improve foot screening and then reduce the risk that they will progress on to then having limb amputation. The national strategies we talked about, prevent, screen, and manage properly, has to be facilitated by various enablers. And one enabler is really proper education and outreach to the community so that they know what their risks are, they're better empowered to do something about it, and for diabetics, they're better empowered to take an active charge of their own condition. Some of these pictures reflect some of the initiatives we've done over the last couple of years, whether it's running out our Let's Beat Diabetes program, and you see these symbols and advertising signs in bus stops, in shopping malls, in taxis and buses as well. And more recently, we've also gone above the line with TV commercials, and some have been very popular. The latest highlights the introduction of our diabetes risk assessment. And we're moving into communities in shopping malls to try and bring this message across. Kung Fu seems to be something that resonates well among our population. We've already had two commercial campaigns based on the Kung Fu theme. Not quite sure whether we'll have another one after this. Right? It's not because it's a war on diabetes, but we were quite struck by how this went viral, and therefore it was an opportunity to seize on it and build on it as well. And of course, we've created multiple points of engagement, getting the public to give their feedback, to give their suggestions, because we want to create a sense of a co-owned journey with the public as we fight diabetes. We've even created other opportunities which are not intuitive to healthcare. In IT, in technology, we talk about designathons and hackathons, and we try to do the same in healthcare to try and create a bed for new ideas to flourish, because we don't pretend to know all the ideas, but the intent is really to now get more people thinking and bringing new innovations to the fore. Of course, the biggest proponent for us took place when National Day Rally came, and PM himself decided to step forward and help us promote the message for diabetes. He doesn't have diabetes, but he was a sterling example of someone who takes an active charge of his own health and then can be a role model for us all. The problem really is that not everyone is so clued in to this outreach thing. This occurred near the start of this war on diabetes campaign. All right? Some of our clusters and hospitals were so excited, they wanted to come together to organize a retreat, to brainstorm for ideas to contribute to our national effort. Then someone walked past, saw the sign, and put it on social media saying, "What is this, a war on diabetes, and you're now declaring a retreat?" So we realized also that as we carry out our healthcare campaigns, we're not always very savvy, all right? But we're learning hard how to be better in doing this, and from now on, we'll always have healthcare advances, all right? No more retreats. The other thing we're doing as an enabler is to empower people, hospitals, care providers, and everyone else with a vested interest in this particular fight, to empower them through giving data to them and encouraging more research in diabetes and diabetes-related treatments and work. we are in the process of creating a national diabetes database. This will roll out in the first quarter of next year, and we will roll out with progressively, starting with first a dashboard at the national level, so we understand where our diabetics are, how they're using services, allow us to then identify where the gaps are, and we want to bring that information back to the hospitals and health systems and various other interested partners so that they can design better outreach activities to reach out to these people who otherwise are not being picked up by our normal screening efforts. We'll create a dashboard also for hospitals to make use of, and a final dashboard which is really intended for clinicians, so that when they are in their clinic seeing a patient one-to-one, they now also know about all the things that have been done for their patient, all the test results, everything, to allow for more holistic care to be provided for that diabetic patient as well. So this is a work in progress, but we hope to have good news announcing when these start rolling out in the first quarter of next year. We've also funded some large-scale and smaller-scale research activities. This is probably the large-scale. Dynamo is what we call a large collaborative grant that's been given out, where they're studying and looking to see whether they can in fact identify a group of people who are already diabetic, but can do various sets of interventions to prevent them from progressing on into getting renal failure. We've given out $25 million to be paid out over a 5-year period of time to facilitate this research. So the point really is we are serious about doing this. $25 million is not small change for any of us, but we think it's worth the investment in this particular area. Predicted is something that is hot off the press. In fact, the announcement about this is going to come out in a couple of days, where Sing Health is going to be running a preventive health strategy and campaign for pre-diabetics, those identified just not quite getting into the threshold to be diagnosed as a diabetic, but we know that those with an impaired glucose tolerance test result are at high risk of progressing on eventually to get diabetes. And they're looking to see whether or not they can do something to intervene there to reduce the likelihood that they will progress on. And we think this is also worth the effort. And you'll hear more of this over the next few days. So what is success for us? The war on diabetes is not a fight that will be won in 1 year, in 2 years, in 3 years, but it's a journey that we will be taking. The intent for us is to create a framework where we want to socialize that change, creating the framework that allows for greater effort to be made. Therefore, in the future, we can build on what we already have. It's a framework which involves multiple partners, multiple stakeholders, both in government as well as in private sectors. We're now starting to engage people that we never traditionally thought we would engage in the journey of trying to promote health for an entire population. And we think these are positive factors. All right, so success for us is when we can create that situation when eventually the curve changes. From the red trajectory you saw earlier in that first graph I showed, maybe down to the green. We can't control for people aging, but if we can reduce the risk of even some people getting diabetes, that's a war worth fighting. Thank you.